See, Dr. Namrata is the most energetic, most powerful, the most academic person in the whole of India, and I'm really proud to be her student. And she was kind enough to be very supportive to KSOs in all our activities. And ma'am will be speaking on what is new in corneal surgeries.
Thank you, Srini, and I would like to thank the sponsor, Cipla, for sponsoring this session. And I would be talking to you about New Frontier Unleashed, which is the biosynthetic cornea. Now, in our country, corneal blindness is the second commonest cause of blindness only after cataract, and so that is why it becomes very important. And we do have limited availability of the cornea in our country, and there's paucity of good quality donor tissue. So this is something which we've worked with our Swedish collaborators, which is a bioengineered porcine construct double cross-linked cornea, which is clinical grade type 1, and it is doubly cross-linked. This is what it looks like. It comes in 12 millimeters diameter with thickness of 100 to 500 microns and has a shelf life of 2 years in the bottle, but has longer when in the eye. And it has gone through all the quality check, including all the investigations like in vitro, ex vivo, in vivo studies and biocompatibility issues. And when you compare it with the human cornea, only the fibrils are a little thicker, and this is how it will look on histopath. So this is your biosynthetic cornea, which looks absolutely acellular. This is the porcine cornea, which is intrastromally implanted, and this is the human cornea. So except for the fact that it is acellular, there is actually no difference between the two, and that too it is inert. And this is how it is implanted. So a femtosecond pocket is made with the help of the femtosecond laser, and this is a keratoconic cornea. This pocket is subsequently opened with the help of the lamellar dissector. This biosynthetic cornea is triphined with the help of trifines, as you would trifine a normal cornea. It is folded just like we used to fold the olden intraocular lenses, and then is placed intrastromally inside, and subsequently is unfolded and then is placed inside right up to the edge of the keratectomy site, and this is followed by a bandage contact lens. So actually there are no sutures also in this case. This is how it looks like on post-op day 1, sandwiched intrastromally, and a BCL which is on the top. This is yet another case of keratoconus and pellucid marginal degeneration both. So in this also a pocket is created, and this patient also has a cataract, as can be seen here. And because there is a pellucid present, the pocket goes right up to the periphery, because that is the thinned out portion. And and then subsequently again this pocket is opened up with the help of the dissector. This pocket is opened up with the help of the dissector, and you can see also in the microscope, operating microscope, intraop microscope, that the implantation of the biosynthetic cornea is then done. And then here you can go right up to the edge of the thinned out portion, because you don't have to suture there. Then subsequently, this is the cataract surgery which was done 3 months later in this patient, and all that you can see is the rim which is present, which is a very thin rim and doesn't hamper the visualization. This is again the post-op picture. Yet another case of keratoconus where this biosynthetic cornea was done, and notice that the Kmax of 85.9 diopters is there, and it is a large cone. This is the post-op picture, and post-operatively it decreases to 57.1. So this is the pre-op picture, and this is the post-op picture, and it regularizes fairly well. And also increases the thickness of the cornea from 280 microns to 570 microns. This is our longest follow-up, so all that happens is that you can see a faint rim which is present all around, very much like your intacs or intrastromal channels, and this is 7 years down the line. This is yet another case which shows that the thickness increases, and this is the ASOCT of the same. Now this was a case of post-LASIK ectasia, and in this post-LASIK ectasia we actually lifted the flap up, and then to reinforce this we created a pocket all around just to fit the biosynthetic cornea there, and subsequently the biosynthetic, notice that this is so thinned out here in the recipient bed is so thinned out, and the biosynthetic cornea is placed now in between to reinforce the thickness of the cornea. And because of this thinned out cornea, probably the ectasia also occurred. So this is the post-op picture of the same, and this is again 89.2 diopters increased to decreased to 50 diopters, and 241 microns increased to 581 microns in post-LASIK ectasia case. This is yet another case where you can't use femtosecond laser because of the corneal haze or the corneal opacity. So you can do dissection with the microkeratome or can do manually. Again, this is the biosynthetic cornea which is being placed here, and here you can glue it because you can't, it's difficult to put sutures through this synthetic cornea. So this can be glued and can be pasted, and then a bandage contact lens can be put. This does take time to epithelize, 2 weeks as opposed to 7 days otherwise, but then it gives good results in these cases also. Now we've done in over 70 eyes, and all patients have had good best corrected visual acuity of 612 or better with no rejection, inflammation, vascularization, scarring. This is the confocal microscopy above and below it, which looks normal, endothelial cells and nerves. And I think in future what we are looking at is that we don't require any eye banks, any media, any laminar flow hood. I know this is far-fetched, but I'm sure it will happen. I hope it happens in our generation, because we've been hearing right from the beginning that there's paucity of good quality donor tissue. So it is potentially safe and simple surgical approach, not dependent on human donation, no graft rejection and failure, no suture related problems, no eye bank facility is required, and it does not preclude a human graft transplant if required, although we didn't have to do in any case. What we are now working in our lab, and ICMR has sanctioned a project for the same, is we are trying to grow endothelial cells on this stromal construct to make a complete corneal construct, and I think that is going to be the future of cornea. So, and this with our Swedish collaborators and Iranian collaborators, we published about this in Nature Biotechnology, which has an impact factor of 68.1. And there is a long wait for all the children there and all the patients there. And I think what is going to be the future is just like IOLs you take out from IOL boxes, from bottles you will be taking out biosynthetic corneas and will be using them as easily as I have showed you. Thank you very much for your kind attention.
Thank you, ma'am. See, when all these new technologies come, the question there is, what about the cost? See, as of now, if this procedure has to happen, what would be the cost, and what do you project over?
So as of now, there's no cost to it because it's a part of our project, but I'm sure because corneal opacities and corneal pathologies which require corneal transplantation generally are prevalent more in the socioeconomic group, which is not very elite, or in low to moderate socioeconomic group. So I think the companies will bring down the prices, because otherwise it doesn't serve the purpose. So the price has to be on the lower side, and we are going to be working on that also, so that the expense is not too much.